see so many folks out today. And delighted to host Tish Moczygemba, one of our colleagues previously from VCU. Now Tish is a professor in the Outcomes Division and at the University of Texas College of Pharmacy. Her program focuses primarily with working with communities and health systems to mitigate the health disparities by developing innovative, patient-centered innovations to optimize medication use and health outcomes. And so today, Tish is going to talk with us about a project that she's been working on implementing diabetes education services and remote hypertension monitoring in community pharmacies. So Tish, I'll turn it over to you. Thank you so much for joining us.
Thank you, Evan. This is such a pleasure to join you today and to kick off the week. I have to kick off the week with you guys. I have to say that I was excited to be invited and really honored. As I was preparing for this talk, I really, really had to reflect a little bit on my experiences as an early academic at VCU. And I think they were such formative years and I really enjoyed them. So it's a pleasure to be among new and old friends. So with that, I will get started. So today I'm going to be sharing with you my team's journey with implementing diabetes education services and remote hypertension monitoring in community pharmacies. I will be focusing really on kind of the implementation and processes that we have used to implement these services. So much of what I'll be talking about is related to factors that help pharmacists become accredited in diabetes education services, and then some of the considerations and lessons learned that we've gone through with implementing a remote patient hypertension monitoring program. As Sydney mentioned, this is the information for CE. So I've had it up. I'll keep it up just a couple more seconds. So those of you who are claiming credit can get that. These are some disclosures. And I do not have commercial disclosures, but portions of this work have been supported by CDC grants. So I'm going to briefly go over today, just at a high level, the prevalence and cost burden of diabetes and describe what diabetes self-management education and support is, or DSMES. And then I will talk about my team's implementation of a program to increase engagement of pharmacists in DSMES. I will then also briefly, is there a question?
Register.
Okay. Then briefly describe the cost and prevalence of hypertension, and then talk about our pilot where we implemented remote patient monitoring for hypertension in community pharmacies. So just at a high level, probably all of you on this call know that the diabetes prevalence and economic impact is great in the US, with 8.7% of adults in the US being diagnosed with diabetes. And we spend over $400 billion each year on care for diabetes in this country. In Texas, our number of Texans with diagnosed diabetes is higher than the average, the national average, with 12.3% of adult Texans having diabetes. And we spend over $25 billion each year on care for Texans with diabetes. And so despite the fact that there have been many advances in diabetes treatments, we still have this huge chronic disease burden where diabetes is concerned. And that is where there has been a focus on increasing engagement of patients in diabetes self-management education and support. So I really started learning about this when we partnered with the Texas Department of Health to work with them to increase pharmacist engagement. At the time, some of you may know this, but I didn't realize that DSMES has actually been around quite a while. Medicare has actually been reimbursing for DSMES since 1997. So that's over 25 years that DSMES has been around. And the purpose, the whole focus of DSMES is to equip patients living with diabetes with the knowledge, skills, and confidence to manage their conditions. And it's really based on increasing efficacy in the patient self-management behaviors. It is the initial year is a 10-hour patient education program that is based on evidence-based, the 7 self-care behaviors. And one thing that really struck me that's highlighted in the National DSMES standards is how it talks about how patients living with diabetes spend less than 1% of their time with their providers. And so that means that the large majority of their time, they have to rely upon their own management skills or sometimes those of their caregivers. And so that really, I think, brings home the point about why it is so important that patients are equipped with these skills. I don't want to get into the weeds for all of the requirements for DSMES accreditation, but there are 6 requirements. At least we worked with the Association of Diabetes Care and Education Specialists, or ADCES, you might see that acronym. The American Diabetes Association also has requirements that are similar, but slightly different. So some of the key considerations as you're thinking about, what might a community pharmacy have to do to be accredited as a DSMES site? So one of them is having a letter of support that indicates essentially administrative support. And so the organization is saying that they are committed to the organization being a site for DSMES. Also, there has to be at least one pharmacist team member who is willing to complete 15 hours of diabetes CE annually. It's also important that you're able to describe the group of patients that you're going to be working with. Part of this is because DSMES can be really tailored to needs. And so the more you know your community, the more you can tailor the services. As you were working on accreditation, it is also required that you have at least one patient who you walk through the program with. So you go through the curriculum at a minimum of 5 encounters. And then you have to document baseline and follow-up data for clinical outcomes. And this, because in the community setting, they may or may not have access to something like A1C. It can be process measures, or it can be behavioral outcomes. So it really varies. And that kind of depends on each pharmacist and their patient and the data or what they may be focusing on in the sessions. And then you also have to have a quality improvement plan. Now, why has there been so much focus on this? So we talked about that, how much time a patient spends self-managing their diabetes. But over the course of this last, 25 plus years, there's also a lot of documented benefits in the literature. And so the average improvement in A1C is about 0.6 when you look across various studies. But there are some that studies that have had success in improving it 1% or more. And then there's other types of outcomes where we've seen benefits that you might expect for a diabetes program, such as improved blood pressure and cholesterol, decreased cost, higher medication adherence, and then just an overall increase in self-efficacy related to management of diabetes. So over time, pharmacists have had roles in DSMES, and they are one type of DSMES provider. When we think about the landscape of DSMES programs, the majority of providers are really either nurses or dietitians, but many other types of providers can provide the service. So there are times that physicians may be part of a team, pharmacists. So I kind of think about this as pharmacists having indirect and direct roles on DSMES teams. So if a health system has a site that is DSMES accredited, they may have a team of people who delivers the DSMES service, and a pharmacist may come in and provide like 1 hour of the 10 hours that focuses on medication adherence, for example. And so in that way, they're not leading the team, if you will, and they're not the coordinator of the service. But they do still have a role on the team. About 1/3 of DSMES programs have a pharmacist involved in one of these indirect roles. And for the focus of this presentation, I'm talking about how pharmacies can have the opportunity to have more of a direct role where they are actually the site that is accredited, and the pharmacist is the one who is the site coordinator, and many times provides the bulk, if not all, of that 10 hours of education. And what's important about this is that if a pharmacy site is accredited, they are eligible to be reimbursed by Medicare. And I do have pharmacy highlighted because it is the site that is accredited rather than a pharmacist. And then when we think about, why would pharmacists want to do this? Sort of what is the value proposition? And so even though I've talked about some of the benefits about DSMES and the fact that it's been around a long time, it's really underutilized. And so less than 5% of Medicare beneficiaries participate in DSMES within the first year of diabetes diagnosis, and less than 7% of privately insured beneficiaries use the service. And so this is really an opportunity for pharmacists, given their footprint in communities, to increase the number of people who are receiving these services. And then, as I've mentioned, one thing that's often attractive to pharmacies is the fact that they can bill Medicare for DSMET once they are an accredited site. And I just want to note, you may see in CMS terminology, they use the term diabetes self-management training rather than education and support. And so I just wanted to point that out, not to get too in the weeds, but you may have seen that. And then, of course, just generally speaking, when we're thinking about DSMES, and even, so for instance, a pharmacist who's doing this at a pharmacy site, they have to work with physicians to get referrals. And so it's also a nice link to the quality measures that many clinics, patient-centered medical homes, ACOs are all working towards to engage provider partners. So that's a little bit of background about DSMES. And then I'll give you a background of kind of where we started with our CDC grant activities, where the main focus was to increase engagement of pharmacists in DSMES. So this was back in 2018, 2019 was the first grant year for us. And as I mentioned, we had heard of I was probably more familiar with the DPP, the diabetes prevention programs. And I wasn't as familiar with DSMES. And so one of the things that we initially did in our work plan was to say, we need to kind of get a pulse for what do pharmacists even know about DSMES? Would they have the readiness and capacity to provide DSMES before we could figure out, how to actually implement tools and strategies to support DSMES accreditation. And so that's what we did. And we actually conducted this survey in the summer of 2020, which, we know COVID was going on at that time. So that was a challenge in terms of getting people engaged even to participate in the survey. But what we learned about those who were recognized or accredited didn't really surprise us, because so we surveyed a little over 100 Texas community pharmacists, and the majority of them either were not accredited or they weren't sure, and just a small percentage were accredited, which aligned sort of with what we thought. But then we also felt, we kind of gauged how feasible would pharmacists think about kind of working to implement some of these ADCES or ADA requirements for DSMES programs. And what we found was that, there was a good level of high ratings of feasibility for pharmacists willing to be able to allocate time, or pharmacies to allocate time to a pharmacist to do some of this. Things like identifying one pharmacist to complete 15 hours of diabetes, and then collecting and analyzing data. And so we felt like there was some good interest in, moving forward with working with pharmacies to engage in DSMES. In parallel to when we were doing the survey, we also connected with CPPI in Texas, and I'm going to hopefully make the correct assumption that because of the work being done in CPPI in Virginia, that the most people know what CPPI in Texas is. This is network of community pharmacies really working to provide enhanced pharmacy services. And of course, if you think about the goals of what we were trying to do with the mission statement of CPPI in Texas, it just aligned perfectly in terms of us working together. At the time when we started our partnership with CPPI, there were about 100 pharmacies in the Texas CPPI network, and that has since, that's constantly evolving, and there's over 200 at this point in time. And I want to give a shout out to our primary partners at CPESN, Benjamin McNabb and Angelina Tucker, who have really been had key roles in this partnership in terms of implementing these services. So I worked, and so Angelina Tucker is our network facilitator at CPESN. And so she and I really worked to develop this program. And so it was a combination of a lot of her experience with some of the existing processes within CPESN and some of the resources that may be available, and then my experience just in general in implementing pharmacist services. And so as part of the program, with the grant funds, each of the selected pharmacies, we would be able to receive funds to cover the ADCES accreditation fee, which is about $1,100. And then we would also develop and provide resources to guide implementation. And so the program included a step-by-step checklist for how a pharmacy could meet the requirements for DSMES accreditation, access to a mentor. This was Angelina Tucker. She is an expert in DSMES, and so she provided both group mentoring and also one-on-one mentoring when needed. We also conducted bi-weekly group conference calls. And this was a way for us to keep connected with our pharmacies and kind of troubleshoot challenges as they arose and together as a team. Angelina used the ADCES curriculum that's based on those 7 healthy behaviors to develop the diabetes curriculum for our participants. And then, of course, we provided just a number of patient resources and pharmacist resources that they could use. And then a couple of other things that we required just as part of the program was, we did kind of track who was coming to the biweekly group calls. So if there was someone, was it still appropriate for them to participate? There could have been other things going on in the environment, all of those things. We also did surveys to kind of gauge how things were going. And then we also had pharmacists sign a letter of agreement. Now we've kind of started doing this with all of our programs, and it's not legally binding by any means, but it just sort of is a way to have that extra layer of commitment to participating in these services. So I also want to spend just a little bit of time talking about how we selected pharmacies. And so we, thought about this. So we had a call for applications, and we thought about Angelina and I really worked together to say what should we consider when we're selecting pharmacies. And so the first one was resources and capacity. And so really, and so I don't think I mentioned this, but CPESN pharmacies are largely independent pharmacies. And so that means that, the resources really vary from pharmacy to pharmacy. But for instance, if you just have one pharmacist on staff, most of the time, that's probably not a good fit to implement another service. And so one of the things that sites that scored higher were those that had multiple pharmacists. There were a handful that had actually dedicated clinical time, where they had a pharmacy resident, a community pharmacy resident that could actually take ownership of some of these things. And so that helped with regards to resources and capacity. We also asked a question about just past experience with implementing diabetes and other types of services. We also wanted to know about existing relationships with healthcare providers. And this is mainly because for DSMES, you have to have a provider referral. And so having some of those existing relationships in place are really helpful. We also considered community need. And this was really what prevalence rate of diabetes was in the Pharmacies county. And then some of the things we also just wanted to know were pharmacist motivation and ideas for partner engagement and sustainability. So this slide summarizes our cohorts. Over the course of our grant, we had 4 cohorts, and collectively over the time, we accredited 25. We helped or facilitated accreditation for about 25 pharmacies. And you can see this was our cohort 1. This ended up, it was a couple of the sites had branch sites. It was a total of 10 pharmacies. Cohort 2 was our most challenging in terms of some of the environmental issues that impacted the setting when considering COVID. There were 2 out of our 12 ended up being accredited, but 10 had to drop out because of constraints that occurred after they had committed to the program. Some of them were COVID-related constraints. Some of them were staffing shortages that happened. And so that was probably our most challenging year, considering kind of the impact of COVID on this. Cohort 3, 6 out of 10. Again, though we're seeing a lot of these things in the environment that aren't surprising to many of you, 3 of those pharmacies had to drop out due to staffing shortages that occurred during the program, and 1 for health reasons. And then our most recent cohort, 7 out of 9 were accredited. And then just to give you an idea about, how did this program, or how did pharmacists view this program? We conducted an endpoint survey. And so overall, we were pleased that the resources and tools we provided seemed to really help pharmacists complete their action items for ADCES accreditation. So for most of these things, the resources that we provided were really helpful. And then these were a couple of the things with regards to establishing a data collection plan to show improvement, or convening a diabetes advisory board. This aligned with our experience, because this is where we had to do more mentoring on throughout the program in terms of helping with data collection plans. So those results did not surprise us at all. And then there are some additional things. So part of the ADCES accreditation is being interviewed by an ADCES staff member, and so we helped prepare for that. This is something that we really think of as a best practice, and we are continue to work with CPSN on various initiatives, and this has become a foundation for us, these bi-weekly conference calls, because I think it just helps everyone sort of move forward together. So there is a little bit of that accountability piece. And so for instance, we may have someone coming very routinely, and then all of a sudden they miss 2 calls. And so we can reach out and say, hey, how's it going? What's going on? How can we help? And then there's also just that accountability piece. And so there is a little bit of that, like, okay, all of these pharmacies have done steps 1 through 3, and I'm a little bit behind. And then, of course, there's that advantage just of sharing lessons learned as we go through this. And so it was very, we did have a portion of the biweekly calls that were structured, particularly at the beginning, but we also had time where we could just share experiences and things about how it was going. So on average, and this really varied, I think that like in terms of time spent completing the program, it really ranged from 12 to 30 weeks. And I think this was just a function. Our most recent cohort was on the shorter end. There was just so much going on in the environment kind of in that 2020 and 2021, that's where some of these longer weeks, that's where that really occurred. And then pharmacists reported spending 2 to 5 hours per week on accreditation activities. And so this was really helpful for us to learn, because when we initially did this, we thought it would be just based on some things that we had seen and kind of thinking about some of Angelina's own experiences. We thought this would be like more than like 1 to 2 hours. And so this was in some cases double what we might have expected. And then this is just a snapshot of some of the facilitators of success. The pharmacist, and this is from the pharmacist perspective, what facilitated them kind of getting to the end of the accreditation process. They talked about the biweekly meetings, and then knowing where to go when they had questions. So this mentoring, this one-on-one and group mentoring really, really helped. And then of course, some of these challenges that occurred, fitting the work in the daily routine, especially with COVID, and then completing training with the patient due to the changing schedule. So post-accreditation, we were also responsible for staying connected with accredited pharmacies. And so what we did in April of 2021 was we launched monthly work group meetings for accredited DSMES pharmacies. And we did a number of things in these sessions. Sometimes we just shared about how implementation was going, and sometimes we invited guest speakers. These are some of the topics that we had for guest speakers. And then we were always increasing awareness about ADCES and other resources. We would also, for those who were coming to having, they have annual reports and different things to keep up their accreditation, we would kind of remind them, we would make sure they were on top of their CE, all of those things. And so that was actually really helpful in terms of people being able to learn as they went in terms of implementation. Now, the grant funding has ended, so these have subsided, but we do think they were really helpful in terms of sharing among pharmacies with implementation. So with regards to the next steps for this, so the funding did end for accrediting pharmacies, but CPS in Texas actually is still utilizing those resources. They launched a cohort 5. And then we're just collectively still continuing to learn about best practices for billing. And we are also, the UT CPSN team is thinking about ways to integrate social determinants of health assessment with DSMES as well in a more formal way. SDOH is a part of the DSMES assessment, but it's sort of a little informal. And so we're trying to do that in a more systematic way. So I'm about midpoint of my presentation, and I have a couple of questions, and I kind of went old school with these, so you can just sort of think about the answer. Which of the following are benefits of DSMES? I also figured it was a Monday, so I'm hoping these are pretty straightforward. So the answer is all of the above. And then which of the following statements is true? Accredited DSMES pharmacy sites are eligible to be reimbursed by Medicare. Accredited DSMES pharmacists are eligible to be reimbursed by Medicare. The majority of Medicare beneficiaries who are eligible for DSMES have participated in DSMES, or none of the above. Great. I see that many of you in the chat are getting this correct. So it is A, accredited pharmacy sites are eligible to be reimbursed by Medicare. Okay. So now I'm going to talk about our experience with remote patient monitoring of blood pressure. And, very, very similar. It won't take me long just to highlight the fact that we have a huge burden of hypertension in this country, and that's particularly important because it leads to heart disease and stroke and all of those things that increase our mortality rate in this country. So we have a large number of adults in the US, almost half diagnosed with hypertension, and we spend over 130 billion. We have a not quite as high as the national average with Texans with diagnosed hypertension. We spend about $50 billion of a year on hypertension in our state. So with regards to this particular aim or activity of our grant, it was a little bit different than, DSMES was very process focused in terms of give pharmacists tools to help facilitate engagement in DSMES, and we were really focusing on accrediting these pharmacies. This one really focused on engaging the provider in referrals, and our team then decided to focus on the hypertension component. So we could have focused on, hypertension, cholesterol. The main focus was on like heart disease and stroke, but the pharmacists and CPSN, hypertension really aligned well with where they were at in some of their programming as well. And so just to give a very brief review of remote patient monitoring, this is something that is sort of one of those emerging and hot topics, but it utilizes technology to allow healthcare providers to monitor patients' physiologic data and manage treatment plans outside of the typical clinical setting. And it can be used to manage either acute or chronic conditions. There's a number of different types of RPM in the marketplace: blood pressure, weight, pulse rate, oxygen levels, blood glucose, respiratory flow rate. And as I mentioned, we focused on hypertension because it really aligned with the overall goals of our funder. And also that it was really, at the time, this is like we started looking into this was late 2021, there was just a lot emerging about pharmacists' potential roles in RPM. There's different roles that the pharmacist can have, patient education, certainly collaborating with different providers and collecting, analyzing, and interpreting physiological patient data. And so I don't want to get into the weeds too much about this because it's a little bit complex, but I do think it's important to understand the type of role that a pharmacist can have under CMS guidelines. So it is important to mention that pharmacists are not recognized as qualified healthcare professionals or clinical staff, which means that they cannot, directly bill for these services without some sort of a partnership with another qualified healthcare professional. And so the way in the RPM language, pharmacists fall under what is called auxiliary personnel, and that means that pharmacists or technicians are allowed to help with RPM. Now, in a traditional physician collaboration, this works very well. If we think about like in a primary care clinic where a pharmacist and a physician are on site, they might have a practice agreement, their employees or contracted personnel to provide the service. So the opportunity for community pharmacy really came in 2020 when the CMS guidelines changed the supervision of auxiliary personnel from direct supervision, which meant that a pharmacist would have to be in the same physical site as a physician, to general supervision. And so because the general supervision allows you to be at different sites, that meant that a community pharmacist could now think about collaborating and contracting with the physician to provide this service. And so we had for us, we had some pharmacies and pharmacists that were really eager to try this and say, what could this look like? And so we did have, we had some experts in CPSN who were just sort of high-level performers in general in CPSN. And they were really vocal about wanting to try this as a pilot to say, like, could we make it work? Would we be able to develop a program that would actually meet CMS requirements for billing? So this is without a contract, and we were able to use grant funds to help with some of the funding for like the RPM devices and the platform, things like that. So considering that, really the purpose of this pilot was to, so if you think about our purpose from our funder, it was really focusing on increasing referrals between physicians and clinics and pharmacists in the community. And then for us, we were really looking at how do we make this work? Like, what would the workflow look like? All those things. And then we were also interested in, we kind of said, well, what, ultimately, if the pilot's successful, we would have pharmacies entering into a contract with the physician after the pilot, because the physician, would have been happy with the outcomes and all those things. And we said at the beginning, we'll be happy, even if at least one, if we can get one, we'll be really happy with that. And so we had an application process that was very similar to what I described for DSMES, with the exception of we had a little bit more of an emphasis on the types of collaborations with the existing collaborations with providers. And so this one is just really important because the goal is to contract with the physician for this service. Those that really had strong collaborations that would be beyond the typical kind of relationship from a dispensing perspective, that was actually really important. And so we placed a little more emphasis on that in the application process. And then we had 6 pharmacies. We were reporting number of referrals, and then we were also paying attention to whether or not we would be able to contract with one of the pharmacies, at least would be able to contract with the pharmacy. And so as I mentioned, the biweekly group conference calls have become a best practice, so that was part of the program. And then we also were able to, as part of the program, pharmacies had access to an RPM platform, which included blood pressure devices for 5 patients. We had a lot of resources for pharmacists to use when engaging providers, and we provided education about pharmacist billing opportunities for RPM and Medicare patients. And then very similar to before, these were some additional expectations. And so with regards to physician interactions, the types of communication with physicians in terms of this initial outreach. So this would be when the pharmacist is first making the kind of the pitch for the physician to be on board as a referring provider for this service. The types of communication across the 6 pharmacies were mainly in person and telephone. And we feel like a best practice for this sort of a service is really in person. Most of the time this was possible. Some were in very close proximity where they could walk to the clinic. Others that wasn't as easy. But that was really looked at as a strength if you could make that initial pitch in person. Now, after that initial follow-up, most of the communication occurred via telephone with the physician or the physician's office. But some did still continue to visit in person. That was mainly the ones where it was, kind of easy to do in terms of getting there. The different types of strategies used when talking about, getting physicians engaged. So we, as part of the program, we developed various talking points for the program that kind of described it and what it would mean, what it would sort of look like. And so all of them reviewed that. Most of them also left referral forms for the program with the physicians, so they could easily sort of make those referrals. And then most also created a list of mutual patients as well. And so that was a great starting point for the providers to see those that where they might be able to make a difference in some of these. And then we also had a flyer that just a couple ended up using. So those were the types of strategies that pharmacists used to engage physicians and kind of get them on board with this program. So across the 6 pharmacies, we enrolled 27 patients. That was really 3 to 7 patients per pharmacy. And thinking about the workflow, so the first piece of this was being referred to, or you had to have the physician referral. And so what we learned from when we were kind of analyzing different RPM platforms was that many of them sort of default to sending the blood pressure machine and everything directly to the patient. But that's also considering that a lot of times these programs are connected with physician offices. And so the pharmacist really felt strongly that that would have a missed opportunity for the pharmacist to have a face-to-face kind of initial interaction and kind of build rapport with the patient. And so what we did was kind of change that default to where anybody enrolled in the program, their blood pressure devices would be sent to the actual pharmacy. And so once the pharmacist received that, then they would contact the patient to come. They would have their initial visit face-to-face, make sure everything with the machine was working and all of those things. And so that seemed to work really well and cement kind of that relationship, because after that, most of the interactions, not all, but most were between the pharmacist and patient were on the phone. So once they were enrolled, most of the pharmacists checked the dashboard daily. If there was an elevated reading, the pharmacist would contact the patient and or provider if it was applicable. And if it was in range, most pharmacists would check in with either weekly to bi-weekly with the patients. Overall, across these patients, there were 18 recommendations to physicians for changes to medication regimens. Each pharmacist made at least 2 recommendations. Here are some examples here. And 50% of the recommendations were accepted. And these, some of them, they didn't accept their actual recommendation, but they still made a change. But there were a couple where the pharmacist really, despite calling or faxing, they just were never really able to get a hold of the referring physician to discuss a potential change. At a minimum, with regards to following up with physicians, pharmacists followed up either bi-weekly or monthly with reports that would kind of summarize how the patients were doing with regards to their blood pressure. Now, the minimum requirement for like an auxiliary personnel with CMS is monthly. So that was the minimum. And then one pharmacy had a physician who requested weekly reports at the beginning. And so but unless the physician requested otherwise, it was bi-weekly to monthly reporting. And then this is just some excerpts from the pharmacist perceptions of facilitators and provider referrals. I've kind of alluded to this before, but having these working relationships with physicians prior to the program were really helpful. In-person meetings on a regular basis, if possible, I think is a best practice recommendation. One pharmacist talked about how selecting the mutual patients was really helpful. And so those were some of the things that kind of align with what I've talked about already. So this, in addition to referrals, we also had this goal of formalizing some of these physician collaborations after the pilot. So we, 3 of our 6 pharmacists actually, they felt really good about the pilot and initiated discussions with providers about moving forward with the contract. One of them actually finalized a contract and is currently working and providing those services today. And then one is still in progress. Now, this funding ended in September, and we need to circle back with them. But this one, just the different channels and trying to get the right person, that's just kind of been taking some time to sort out, but they are trying to pursue this. And then one of them, they had some great and promising feedback from the provider, even had a sample contract as an example and things like that. But ultimately, just for different reasons, the provider kind of wanted to put it on hold. And so that's something that the pharmacist may go back with and, over time kind of follow up with. But overall, I mean, we were happy with this in terms of having one success, possibly 2. I do want to mention just a couple of, so implementation challenges, staffing shortages, that's just a common theme. That's just kind of what's going on in the environment. Staffing shortages kind of just impact various things at various times with these programs. And then the RPM provider that we used, it wasn't very efficient in making physician reports. And so what that translated to was time intensity and a time burden on the pharmacist, because they had to sort of do these manually and kind of copy and paste a chart and things like that. And so that was the biggest, by and large, was the largest kind of implementation challenge. And that was because of the time burden that provided, or that presented to the pharmacist. And it really was, if you think about the pharmacist who was doing these reports weekly, it really was a time burden on them. So it really was a major implementation challenge, if you will. So with regards to next steps, we have this kind of workflow that we feel pretty good about, and we are excited that we're going to be continuing some of our work with Texas Department of Health to expand the hypertension RPM to pharmacies in regions of Texas with high prevalence of hypertension rates. And then we're also going to be focusing on some social determinants of health with that as well. This is very much, we're still kind of completing our work plan and different things for this, but one of the highlights here is that we will be working with our Department of Health to really identify some of these they're really targeted in these high areas with high prevalence of hypertension. Okay, so that concludes my summary of our journey with RPM and a couple of questions. So for RPM, CMS recognizes pharmacists as great. I already see the right answer, B. My slide is stuck. And then which of the following are roles for pharmacists in RPM? Correct, C. That concludes